And continue.
Very good morning, everybody, and thank you, PCSI. Moving towards my topic, that is diastolic flow reversal in aorta. Whenever we talk about diastolic flow reversal, wide pulse pressure, the two main lesions, basically ductus arteriosus and aortic regurgitation, come to your mind. But other than these two lesions, there is a lot of list which can lead to flow reversal into the aorta, proximal aorta. This is an echo picture of a usual an infant with CHF, pH, wide pulse pressure, and there was a large ductus arteriosus. Plus, there is a color Doppler across the long axis view of the aorta, and you will find there is flow reversal. Flow reversal here very classically from lowers towards the PTA and from the upside, because it is a continuous flow into the pulmonary circulation, and this is the M mode. From the upper side, there is downward flow during diastole, and from lower upward flow, that is reversal into pulmonary circulation, leading to large shunt into pulmonary artery in the case of ductus arteriosus. The child underwent closure for the PDA and doing perfectly fine. And this is in contrast to the previous long axis of the aorta up to the proximal, means up to the ascending aorta, there is flow reversal. M mode across the aorta showing pan-diastolic flow reversal in contrast to PDA, where there were blue. And so that is a typical, very beautiful picture you will get by the M mode of the color Doppler across the aorta in different type of the runoff lesions. Other than ductus arteriosus and aortic regurgitation, let's search towards the other causes. And this is aortopulmonary window, large AP window with confluent, means involving the origin of the right pulmonary artery from ascending aorta. So huge aortopulmonary window with origin. Obviously, you will get a flow reversal up to the ascending aorta in this case. And the child require early surgery, neonatal infant presentation, and surgical correction is the answer. This is less common entity where you have in the previous you have a AP window plus RP from ascending aorta, while here this is isolated right pulmonary artery or isolated left pulmonary artery from ascending aorta could be the entity. So in this case, main pulmonary artery is continuing to left pulmonary artery, while the right pulmonary artery is arising from the ascending aorta. So the arch will give you a clue. The child clinically having CHF, pH, wide pulse pressure, in aorta there is flow reversal, intracardiac almost normal heart, no septal defect, there is no PTA. So you need to find for these less common causes leading to the flow reversal into the aorta. And truncus arteriosus, you all know, a common trunk giving rise to pulmonary artery, main aorta, and the coronary arteries. And because of runoff into the pulmonary arteries, the pulmonary circulation is getting flow from common trunk. You will get same like in aortic regurgitation, same pan-diastolic flow reversal into the aorta. And then the coronary fistula, if it is large, the shunt significant, that will also lead to present as a runoff lesion or flow reversal into the ascending aorta. This is again a less common entity. A newborn presented with features of CHF, and this is parasternal long axis view. Clinically, there was aortic regurgitation, and look, aortic valve is okay, but there is a separate jet of aortic regurgitation, basically aorta left ventricular tunnel, leading to presenting as a case of the congenital aortic regurgitation sort of. And again, in this case, this can lead to fetal cardiac failure or neonatal cardiac failure, depending on the site of the tunnel. This tunnel may open into LV, right ventricle, or pulmonary artery, like rupture sinus of Valsalva. So anywhere from aorta tunnel can open, leading to features of the congestive cardiac failure, and the correction of the closure of the defect is the answer. So this newborn also underwent surgical correction of the aorta LV tunnel and doing perfectly fine. Nothing was needed for the aortic valve as it was well coapting. And then in the older patient with short history, acute onset of CHF, large shunt because of rupture sinus of Valsalva, this T showing RSOB into inflow of the right ventricle, and the patient underwent device closure. So closure is the answer when there is a large shunt with runoff into the aorta. VSD, aortic valve prolapse, severe aortic regurgitation, you all know that is the known entity leading to aortic regurgitation. But there are the situation when you don't find anything intracardiac leading to this flow reversal into the aorta. Then you have to look for the extracardiac causes for it. And this is, for me, a newborn, small infant presenting with these features, means CHF, PH, features of flow reversal in aorta, nothing intracardiac. It's as a policy, you have to put your probe over the head and over the abdomen, over the liver. So you need to rule out extracardiac causes leading to runoff lesions. And this is a newborn with a large vein of Galen malformation. Pulsatile vessel, large shunt is seen into the cerebrum, and the child underwent coil closure in neonatal period. The timing is very important for these things, because these fistula, vein of Galen malformation, can be, if in a detailed antenatal ultrasound can be picked, and in the early neonatal period you need to plan the intervention. If you delay for the procedure, the cerebral atrophy happen, and obviously your neurological outcome will be compromised if you do intervene. So timely diagnosis of these things are important, and that echo also give you a clue. Even in fetal echo, the flow reversal into the aorta going into the cerebral circulation. And this is a 2-month-old child, features of CHF, same presentation in all these patients. You can see a volume loaded heart, pulmonary artery dilated, there is tachycardia, LV dilated, and this is the flow reversal, pendiastolic flow reversal up to the proximal aorta. On echo, I could not find anything, but there was a murmur, and we did a CT angiography to look for the, there was a fistulous communication between the subclavian artery and the pulmonary artery. Very distally, the child underwent device closure for the same. So clinical examination is very important, and a subtle clue on the echocardiography to find the remote causes, distal causes for the flow reversal or the white pulse pressure you need to search for. BT shunt, left, right, or bilateral is acquired post-surgical intervention leading to the same the presentation. So structural causes, just to enumerate, the PJ, that is the commonest one, then AP window, PA from ascending aorta, truncus arteriosus, congenital AR or aorta LV tunnel, sinus of Valsalva rupture, various causes of AR, the long list of aortic regurgitation, bicuspid, subaortic membrane, infective, traumatic, post-balloon dilatation, root dilatation, aortic dissection, VSD, aortic valvula. So long list is there, all presenting with the white pulse pressure with runoff lesions. Extracardiac things, vascular malformations, vein of Galen, branch PF from ascending aorta, coronary fistula, and the BT shunt. So these are the structural causes. But beyond structural, you have other hemodynamic causes, which will also lead to diastolic flow reversal into the aorta. So list is long, but causes, always these are the significant causes. If flow reversal is there, you need to find the explanation for that. Aortic stiffness, systemic arterial hypertension, that is one cause. Especially with the age, you find this flow pattern in elderly patients. Then low cardiac output, obstructed TAPVC or severe left ventricle. Basically low cardiac output, whatever the reason, low cardiac output is there. There is rise in systemic vascular resistance, rise in the diastolic pressure, and in proximal aorta, you will find this flow reversal. This is early to mid diastole, not pendiastole. So that is the difference between, and that points towards, it's more of a poor prognostic factor when in a sick patient you find flow reversal into the aorta. And then the high cardiac output stays, anemia, thiamine deficiency, hyperthyroidism, liver cirrhosis. Chronic liver disease have many impacts over the heart. One is the increased volume, pulmonary malformation, pulmonary arterial hypertension, wild pulse pressure, anemia. So a lot of things happen over the heart. Hypoalbuminemia will further lead to your exaggeration of the volume. So many factors, many effects of the liver disease on the heart. You need to have a different mindset to do echo in patients with the chronic liver disease. This is echo of an infant with the obstructed TAPVC, the bad heart, dilated right side, hugely dilated, severe RV dysfunction, moderate regurgitation, severe pulmonary arterial hypertension, and this is the color Doppler M mode. You see just early diastolic flow reversal is there. And this is the aortic view of a patient with dilated cardiomyopathy, non-compacted with mild regurgitation, not significantly anemic. Pulse pressure is also not, is okay for this patient, but this flow reversal means aortic stiffness, aortic wall as such is misbehaving in these patients, because not all DCM severe dysfunction have this flow pattern. So these patients behave differently. You have to optimize these medications in these patients differently. When you go distally into the aorta, the flow pattern in the distal vessel is like this, means systolic, and you have initial flow reversal, then a slight antegrade. flow. This is the usual pattern, but this pattern in sick patient you find in the proximal aorta also. So the resistance which is provided by the distal vessel, means a smaller vessel is getting, the resistance is increasing. Same cheese is transmitted, is reflected into the proximal aorta in these sick patients. So we need to have a watch over the aortic flow pattern in ICU patients especially. This is just an article about the RV dependent cardiac output, where there was a flow reversal. It correlated with the poor prognostic factor in these patients. This is just totally, yeah, it's just reverse. This is a duct dependent systemic circulation. So you look at the flow pattern. This is a PDA, left to right shunt. This is PDA, right to left shunt. So duct dependent systemic circulation in a case of hypoplastic left heart syndrome, ascending aorta, arch branches being filled by the PDA, and descending aorta is getting. So it is a systolic. So systolic downward flow and systolic flow reversal into the aorta in case of duct dependent systemic blood flow. So take home message: flow reversal in aorta. You have to be vigilant. You have to search for the causes. PDA, aortic registration, common thing, but you have a long list of structural causes leading to cardiac failure. You need to intervene these patients early. When it is hemodynamic cause of flow reversal in aorta, you have to optimize your medication because these are the sick patients. Another list entity to add here is the multi-system inflammatory disorder. A big number of patients, almost 25% patients are coming with flow reversal. They are not sick patients. So probably aortic stiffness is happening in these patients, like my 200 patients flow reversal. So that is another thing, long-term follow-up in these patients. You need to know what this COVID is going other than coronary on the aorta also. Thank you.
Thank you, ma'am.
Thank you, ma'am. Wonderfully